For any clinician supervising a rehabilitation program, it is essential to understand the biomechanics of the joint they are looking at. There are two types of movement that we can discuss about around a joint. The first type of movement is osteokinematic motion. This refers very much to the physiological movements that result from concentric or eccentric contraction of overlying muscles. The second type of movement is arthrokinematic motion. This is an understanding of the relative movement of one joint surface to its neighbour. Physiological movements are voluntary. Accessory movements are movements that cannot occur in isolation by primary muscle action, and these accessory movements may be an integral part of the physiological movement. The two often occur simultaneously. In order for full physiological motion to take place, the accessory movements must be present and full. If the accessory movement is inhibited in any way, then there is a significant loss of physiological motion. A muscle or a joint cannot be fully rehabilitated unless it is free to move through its complete range unimpeded. On assessing the physiological motion, the accessory components of that motion must also be observed. So, for example, where we've just gone through the motions of the shoulder girdle, elevation, depression, protraction and retraction, and medial and lateral rotation of the scapula, each of those movements will have each of those movements will have accessory components to observe. The same is true when looking at the glenohumeral joint. The glenohumeral joint moves through flexion, extension, abduction, adduction, and medial and lateral rotation. And in order for those movements to occur completely, it's essential to understand the accessory movements that occur between the humeral head and the glenoid fossa. All movements can be described in terms of spin, roll, and glide. Spin occurs about the longitudinal mechanical axis of the joint. This is a rotational movement and can be either clockwise or counterclockwise. Roll, on the other hand, is an angular rotation, where one articular surface rolls on its neighbour. Glide is a translational movement, where one articular surface will slide along the opposite articular surface. For a full review of spin, roll and glide, it's suggested that you look at the introductory chapter in arthrology in Gray's Anatomy. There are a number of passive accessory movements that the clinician would want to assess around the different joints. The glenohumeral joint is important to assess, in particular, inferior glide of the humeral head relative to the glenoid fossa, posterior glide, and lateral distraction. It's also important to assess anterior glide. The acromioclavicular joint, anterior and posterior glides are important, and shearing of the acromioclavicular joint. And at the sternoclavicular joint, anterior and posterior glides, superior and inferior glides, so starting at the sternoclavicular joint, the physiological movements that we have are movements of elevation, depression, protraction and retraction, and axial rotation of the clavicle occurs during medial and lateral rotation of the scapula. The sternoclavicular joint, remember, is a synovial saddle joint. On the clavicle, in a superior to inferior direction, the articular surface is convex. On the sternum, it is concave in a superior and inferior direction. In an anteroposterior direction, the sternum is convex, and this time the clavicle is concave. This diagram shows the shape of the articular surfaces. demonstrating the sternoclavicular joint being a typical synovial saddle joint. Remember, there is a disc that improves the congruency between the two articular surfaces. So when we look at the movements of elevation and depression, as the clavicle moves on the sternum itself, there's approximately 45 degrees of elevation and about 10 degrees of depression. As the clavicle elevates, so as we shrug our shoulders, for example, what we see is we see a superior roll of the clavicle with an inferior glide. So if a patient came in complaining of a loss of elevation as a result of stiffness or pain arising from the sternoclavicular joint, the clinician would assess the physiological movement of elevation. They would get the subject to shrug their shoulders, and they would then go on to assess the ability for the medial end of the clavicle to glide inferiorly. So they would apply pressure, they would push down on the medial end of the clavicle itself. The opposite occurs during the movement of depression. When looking at the movement of protraction and retraction, this time we have a concave surface moving on a convex surface. There's about 15 to 30 degrees of protraction and about the same amount of retraction. Okay, so as the subject retracts their shoulder girdle, so as they bring their shoulder girdles backwards, there is a simultaneous posterior roll of the clavicle on the sternum and a posterior glide of the clavicle on the sternum. So as the clinician observes the movement of retraction physiologically, the next thing to go on to do is to assess the glide that occurs at the sternoclavicular joint. So an antero-posterior pressure is applied to the medial end of the clavicle. The opposite movements being true for protraction. It's important to note that when the shoulder joint, when the arm is elevated through abduction or through flexion, as the scapula rotates laterally, tension in the coracoclavicular ligament leads to a posterior rotation of the clavicle about its long axis. This is a rotation of about 40 to 50 degrees, and this rotation is essential. An inability for this to rotate leads to an inability to fully elevate the arm. Okay, movements of the acromioclavicular joints again are elevation, depression, medial and lateral. Protraction and retraction, and then medial and lateral rotation of the scapula. The AC joint this time is a synovial plane joint, so most of the movements that occur here are essentially gliding joints. Okay, as the scapula elevates, again, so as we shrug our shoulders, there needs to be free movement of the sternoclavicular joint as already described, and free movement of the acromioclavicular joint. As we see the movement of elevation, so as we shrug our shoulders, the shoulders are brought upwards, there is a superior movement of the acromion, or a relative downward movement of the clavicle. The reverse occurs during depression. In the movement of protraction and retraction, the scapula is seen to move around the thoracic wall, and as it does so, there is a relative anterior movement of the acromion relative to the clavicle, or a posterior movement of the clavicle relative to the acromion. Again, the reverse occurs as we go into the movement of retraction. Again, this means that the clinician, in order to assess the movements of elevation and depression, in order for effective elevation to occur, we must have adequate relative inferior movement of the clavicle relative to the acromion itself. The reverse being true for depression. For effective protraction to occur, there must be a relative posterior movement of the clavicle relative to the acromion process. So as the scapula is brought forward, as the acromion is dragged forward, it's got to be able to slide anteriorly relative to the clavicle itself. Upward and downward rotation refers to movement of the rotational movement of the scapula itself. So movement of the inferior angle away from the midline, which is lateral rotation or upward rotation, and movement of the inferior angle towards the midline is known as downward rotation or medial rotation. As we move into lateral rotation, there needs to be a relative superior shearing, a superior movement of the acromion process relative to the clavicle. Again, this can be assessed by applying inferior pressure on the clavicle itself to see whether the clavicle is capable of moving downwards relative to the acromion process. It's difficult to take a hold of the acromion process and shear it upwards, so it's easier to try to move the clavicle rather than moving the acromion process. When we move on to the glenohumeral joint, the glenohumeral joint is a typical ball and socket joint. So the humeral head is biconvex, the glenoid fossa is biconcave. As we go through the various motions of the glenohumeral joint, so if we start off with looking at abduction, the humeral head will roll superiorly on the glenoid fossa, and there is a simultaneous inferior glide of the humeral head. This is essential to keep the humeral head centered in the glenoid fossa. On adduction, the reverse occurs. As we look at flexion and extension, this can be described in terms of spin. So as we move through the movement of flexion on the right shoulder, what we see is a counterclockwise or an anti-clockwise spin. As we move to extension, it is a clockwise spin. On internal rotation, on medial rotation of the glenohumeral joint, we see an anterior roll. The head of the humerus has to roll anteriorly relative to the glenoid fossa, but again, to keep the articular surfaces centered, there needs to be a simultaneous posterior glide, and the opposite is true for external rotation. So, for full motion to occur, it is essential that we clinically assess the ability for the humeral head to glide superiorly and inferiorly, and anteriorly and posteriorly. Having completed our active ranges of movement and looked at the relative accessory movements that occur at the sternoclavicular joint, the acromioclavicular joint, and the glenohumeral joint, we then move on to resisted muscle testing. And once again, the aim is to assess for symmetry and or pain. At the shoulder girdle, we would assess all of the anatomical movements of elevation, depression, protraction, retraction, and then the ability for it to medially and laterally rotate. At the glenohumeral joint, we will be looking at flexion, extension, abduction, adduction, and medial and lateral rotation. And just like any other joint, the movement is performed isometrically, initially in its mid position, but then we could move into a shortened or a lengthened range of the muscle, and if we still find nothing there, we may choose to move on to isotonic as opposed to isometric movement. This resisted muscle testing is then graded according to the Oxford scale, as we can see here, where grade 0 is nothing, grade 1 is a flicker, grade 2 is a movement with gravity assisting or transferred, grade 3 is a full range of movement against gravity. Grade 4 is the vague grade where it's movement against gravity with resistance, and this resistance can be a significant amount of resistance, or it can be just a small amount of resistance. And grade 5 is what we would accept as normal when comparing it to the uninjured side.